Okay, so we're going to move into the Q&A portion of today's presentation. Thank you very much to all of our presenters. Very great, engaging information and a lot of questions popping up in the chat. So for our first question is for our Alberta friends. Carlin is asking, I would love to bring this model back to my management, wondering if the roles that you utilized in the program were already existing or if they were new and required new funding.
Jennifer. So I'll just, yeah, the roles were already existing. We didn't require new funding because there was general frustration across each sector. They just didn't know how to connect the dots. Mm-hmm. And so.
Can I add? One of our stipulations actually was that we couldn't have any new funding. We were told very clearly there's no money for any of this. If you want a guide as to how we did this project, we can actually, you can Google.
Great, thank you very much. The next question is from Aaron, and I believe that this was for Alyssa and Fred. It just came in at the end. Just can you share some more information on what your average caseload is?
Sure. So we'll carry anywhere between 2 to maybe 10 in hospital, depending on what's going on. Between us, probably up to 15. And then in the community, probably the same kind of numbers. So we're probably in a range of, anywhere from sort of at any one time from 10 to sort of 30 or 35 or 40 patients, depending on the activity. And what we do find is that some are much more active than others, and then some are pretty basics.
Great, thank you. Alzera has asked, she says, Alyssa, this is a great work that fills many gaps in the transition between systems. Do you know if there's any communication between hospitals about how this model can potentially be adopted for better continuation of care for people experiencing homelessness? Also, I'm curious to know how you identify people experiencing hidden homelessness.
So for the last question, for people who have hidden homelessness, we do a pretty good job at finding out who is homeless and who is not. We haven't really actually come into any issues where people are being discharged and all of a sudden we find out that they have nowhere to go. So it's usually people want to get our services and people are very happy to have us involved in their care. It usually means a more comfortable hospital stay, and it also usually means better support in the community and access to different things. So I guess if we did have an issue with that, it's mostly about how we communicate with people. And so just finding ways to better suss that out while people are in hospital, I would say would be the best way to do that. And with regards to I think you're asking if this program is sort of throughout other hospitals. The one that Fred and I are working on right now is actually currently part of a research project to hopefully expand those into other hospitals. I think we're going to link the research in the chat so you can take a look at that. But as far as we know, there is not a program that's similar to ours that does both inpatient and community work with the same staff. We don't know of any like that, at least in the city.
We're also embedded in the floor so that we have access to their medical records. So that's a huge plus, right? The information that we have access to is, it's for people both in hospital, but also for the external, community partners that are asking things. We've got all that information.
Thank you, and that leads well into the next question. It's been posed by a couple of people, and I'd love to pose it to both of you. And there was some discussion in the chat, but I think this is a big conversation. And that is, how are people navigating the sharing of health information? So is it just being shared with health providers? What does that connection look like with the housing sector? So whoever wants to take that one first, I'd love to hear from both of you.
I'm happy to start with our group, and then Sarah and Shogi, please jump in. But that was one of the challenges that we flagged initially as a very significant challenge that we needed to figure out very quickly. So the community paramedics were selected in part to address those concerns because they flow between acute care and the community, and they're an AHS provider. And so we found that hospital staff were a lot more comfortable passing information over to community paramedics because they were AHS providers. And then community paramedics had very close relationships with all of the organizations within the community serving, the homeless serving sector of care. And so then they were able to pass health information on from there. Sarah, Shogi, do you want to jump in at all?
No, you said it perfectly. I think that's one thing we consistently struggle with, that in this age of technology, where a lot of things can be done, where you can provide role-based access according to the necessity, and probably sector-based access, that we have different vendors and different technologies that don't talk to each other. And since we cannot change the system, we're using a human-based workaround to share that information. That's what because ultimately we want to get these folks into the proper care as they transition into the community. So one of our workarounds is the community paramedics who are acting as that bridge between the two sectors.
One of the first things that we do is get consent for a variety of people out there in the community, and then because again we're embedded into the internal medicine program at St. Mike's, we're part of the circle of care, so that makes a huge difference for the hospital care.
Great, thank you. Next question is coming from Jesse for Fred and Alyssa. Can you tell us some of the key challenges that you experience in doing this work?
I would say one of the biggest challenges that we have is around supporting the hospital to have an understanding of what the needs are of this population, and getting buy-in from our colleagues. And now, we've been on the floor for some time, so and we are sort of a downtown hospital, so we generally understand the needs of the community, but I think that's one of the biggest pieces, is knowing that the care looks a lot different. People's priorities are very different, and the way we approach people is very different. And so that is definitely one of the biggest challenges, finding somewhere for people to stay after hospital, particularly when they need nursing care or physio or OT or anything like that when they're done at the hospital. Going to like a regular shelter just really doesn't work. And so Fred has actually really done a really great job of developing partnerships with different hotel programs and other shelters that people can access these supports at, that have more privacy, where we know that the staff at those residences are more engaged with people, and they'll look out for the community supports that are coming in and help people arrange their appointments and care while in the shelter. So that's been really, really challenging, but also we've found ways to sort of work around that, which has been really good.
Yeah, and I think what's important is to understand the kind of volume. So, St. Michael's Hospital our emergency department sees 200 people a day, sort of regardless of what day it is. So, and of that population, anywhere between 10 to 20% of that are homeless. So we're getting a big, a big population of homeless people coming through our doors in the emergency department, and then obviously another percentage of those are coming to internal medicine, which is very high because this is where they come. So, I think Elisa hit it right on the nail that some of the challenges we have. I think, I think we're challenged sometimes with our colleagues in psychiatry and addictions, because the community tends to be further ahead sometimes in their development of models and their development of care than is in hospital, and the hospital's slow to catch up with protocols. So, we're struggling with trying to, satiate people's opiate needs when they hit our emergency department, because they're coming in and, often with safe supply and very high, high levels of opiate support. And we're just not able to even, we had a patient the other day that came in and we couldn't even give them what they're being prescribed in the community, because it was above whatever protocol we have in the hospital. So I think that I find that to be one of our biggest challenges, because that population is underserved all over the place at the best of times.
Thank you for that. And you speak a lot about, buy-in and having the right people at the table. And I'm curious to hear from our friends in Alberta. There's a lot of people engaged in your process. And there were some questions coming in the chat wondering if you are engaged with the police or your emergency department. And I saw you guys answering that, which is great. I'm curious to know, how did you decide who to engage with first? And what was the buy-in experience like for you? Were people on board right away? Was there any resistance to change?
Great. Yeah.
Go ahead, Chogi.
That's a great question. As Jennifer explained on the slides, the first thing we had to do, because it was pretty ambiguous where we wanted to go and where we wanted to start, but we interviewed a lot of the people who are already in the homeless shelters to figure out what are some of the interactions they go through. So a lot of journey mapping happened in the beginning to figure out what were those crucial points of interactions. It's a complex, as you all know, is a complex system and a complex patient. So, but we decided what can we crucially focus on that can in major way take care of 60 to 70% of the transitions issue, being focused on our intentions. And from that, we decided just these stakeholders would be the main drivers of the change. So rather than involve every aspect that's involved, just try a small prototype with a few people involved in their care that can move the needle. And then as the momentum goes on, then we can build on it and keep adding more stakeholders if the model works. Jennifer?
No, and just adding to that, one of the crucial things of the project that we've maintained all along is to make sure that we've got a fully informed perspective from acute caring communities, and we made sure strategically between the three of us that the priorities of either side would not dominate, and so you see that reflected in our core team as well. And so being able to drive in parallel and bridge those two systems, I think people really saw that we were trying to do that, and that helped with the engagement as well. Sarah, do you have anything to add?
My only addition is that we cast a very wide net early on, like people noticed. And then we had to decide pretty quickly what steps we can take to move forward with the people who were engaged. And that meant that some of our service providers, whether in Alberta Health Services or out in the community, if they didn't engage, we would just take a step forward without them. However, we would keep circling back to the community and keep bringing back our results to people, even if they weren't engaged, just to give them that constant opportunity to re-engage with this project. And some people capitalized on it and some people didn't. And we just did our best with what we could. This was a very, there's like that 15% model of thinking, which is like, what can I do with the minimal resources that I have? And we just kept that front of mind in every step that we took. We have this many resources, what can we do with this much? And I think that it ended up piling on to a pretty big impact in the end. So we were very lucky.
Thank you. And I also loved the comment made about, along the lines of just being really clear on your aim and being really focused on what it is that we're trying to accomplish here. So great, a great point. We have another question from Brad for Alyssa and Fred. How do you transition the clients you work with onto other services once they are stabilized in the community? Are there agreements with community-based programs? I suspect your caseload would be large if you kept working with all the clients you get connected to on inpatient units.
This is a real challenge, obviously.
Yeah.
Right? I mean, we are lucky that some of the programs that are out there are very, very strong in our community. I think that one of the big successes we've had through COVID has been our hotel program model that's opened up, and there's nurse practitioners in the hotels in a lot of the bigger hotel programs, so we've been able to transition some people to care there. We've been able to transition people to care through their family doctor or we've tried to connect them to family health teams that have wraparound supports in community health centers that have those wraparound supports. I think.
Yeah, and I think we've sort of done a good job at finding people who do longer term work with the exact community that we're working with, and we sort of have these, I guess they're not really contracts, but this unwritten rule of you look for my people while they're in the hospital, and and so we help each other out, and they're not really written in stone, But it is a very small community, and because we have such great access to people's healthcare while we're in the hospital, it's helpful for our community friends who are doing the same thing out in the community. So we try and work with that and refer people to those programs when they're ready. And again, like we do work with some people longer than we technically should on paper, but in the end, people generally get the care that they need, and we have good flow.
And I think, you're talking about challenges, and one of the, with bragging a bit, I think, Elisa and I have come out of the community and we're strong community workers. And I think it's not an easy thing to pass a challenging client off to somebody who's relatively new, and sometimes you've got to sort of work with that person a bit. There's a bit of peer mentoring that happens to sort of try to get them up to speed, and just sort of have to do that, right?
Great, thank you. So unfortunately, we are just about out of time. I will just direct people's attention to a couple things. One is that Erin had just made a comment that she would love to receive a copy of program models and policies if people are able to share. I will also just say, if folks have not been following the chat, there's been a ton of great conversation and resources being shared in the chat. I apologize, I wasn't able to keep up with everything and get all of the questions asked. The chat and Q&A do still live with the session, so feel free to pop in and ask a question if it didn't get raised. Presenters, you can also respond in writing. Otherwise, I would just like to again thank all of you for presenting great, really informative presentations, really great work going on in both of your communities today. So thank you so much for that. Thank you to all of our attendees for joining today and for engaging in the chat and in the Q&A. I would just like to remind everyone that if you scroll down to the bottom of your screen next to the discussion tab, you will see the evaluation tab, and we would encourage everyone to complete the evaluation. Let us know what you thought of this session. And finally, just a reminder that in about 15 minutes, you can head back over to the main conference session where we will be having the closing, including the closing prayer. That will be starting at 2:45 Eastern time. So again, thank you everyone, and have a great rest of your day.
Thank you, Tara.
Thank you.
Thank
Keep up the good work.
you.